Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for April 30th, 2025. Thank you for joining us today, and thank you to the current Osteoarthritis Action Alliance sponsors shown here who help support our work, which includes the monthly Lunch and Learn webinar series. We are very excited to bring you an extra edition this month to help us get a jump start on Arthritis Awareness Month activities, which we will be promoting during the month of May. I am pleased to introduce Dr. Belinda Lawford. Belinda is a musculoskeletal researcher at the Center for Health, Exercise, and Sports Medicine at the University of Melbourne, Australia. Her research focuses on clinical trials and qualitative studies of treatment strategies for people with osteoarthritis, in particular, digital delivery of care, exercise, and weight loss. Her research aims to develop and evaluate strategies to improve the management of osteoarthritis in Australia and worldwide. The title of today's presentation is Digital Delivery of Osteoarthritis Lifestyle Care. Welcome, Dr. Belinda Lawford.
Thank you. Thanks so much. Thanks for the invitation to present on this topic. Before I get started, I just want to acknowledge Professor Kim Bennell as I adapted this presentation from one she delivered at a conference last year. So she kindly let me adapt a lot of her slides. So, as many of us will know, clinical guidelines, including those from OARSI, emphasise the key role of lifestyle management for OA. So, particularly education, exercise and physical activity, weight loss for those who have overweight or obesity, as well as other pain management strategies. But there are barriers to uptake of these treatments. So, factors like costs or difficulties accessing some health services can make it hard for people to engage in these treatments. And in some areas, there can be a scarcity of appropriate healthcare services like physiotherapists or dietitians, for example, particularly for people who might live in rural or remote areas. So, one way of potentially overcoming those barriers to uptake of care is through digital health. And this really enables people to access treatment and advice from the comfort of their own home, increasing access to care, as well as potentially reducing costs for many people. So, there's a range of different digital approaches that can be used. So, obviously, care can be delivered by healthcare professionals via telephone or video call. Websites can also provide information about self-management of OA, and tools like SMS and mobile apps can help people engage with different treatments, such as exercise. So I'll go through these different modalities sort of one by one and present some of the evidence that supports the effectiveness of these different types. And just acknowledging that much of the work I'll present has been done by Chesham, the research centre I work in, just because it's a little bit closer to home, but of course acknowledge that there's a lot of other work in digital health in OA out there as well. So I'll start by focusing on telephone delivered care, and this is obviously a very readily available and easy to use mode of service delivery, with the caveat, I guess, that it doesn't provide any visual contact between the patient and the clinician. But nonetheless, it does have a potential role, which I'll hopefully show in some of my next slides. So this trial published in BJSM a couple of years ago now aimed to evaluate the effectiveness of telephone delivered physiotherapy in 175 people with knee OA. And this was compared to an education control. So briefly, this involved prescription of a home exercise program and between 6 to 10 consultations with a physio over 6 months. And that education control comprised a single telephone call with a nurse on a musculoskeletal helpline, where participants received sort of general advice and education. So results from this trial indicated modest benefits for physical function, but not for pain at 6 months. And this wasn't maintained at 12 months. But a lot or most of the secondary outcomes favoured that telephone intervention, including things like pain on daily activities, walking pain, self-efficacy, global improvements, and also people's satisfaction with the intervention. So some qualitative research that I led also found that, contrary to popular belief, patients and physios were able to develop a strong therapeutic alliance over the telephone, which was comparable to what's typically observed when they consult face to face. Similarly, we interviewed participants and physiotherapists who participated in that trial, and we found that although both were initially pretty skeptical about the effectiveness of telephone delivered care, after they'd experienced it firsthand, they found they actually really liked it. So they sort of perceived some unique advantages of telephone delivered care, including that it was obviously really convenient and accessible, but also that it actually enabled a more personal conversation and empowered that patient to self-manage their condition. But as you can see, there was a perception from both patients and physiotherapists that some kind of visual contact would have been desirable. So the next modality I want to focus on is video conferencing or video calls over things like Zoom or FaceTime. And again, this is a widely available mode of technology, and it obviously enables visual contact between a clinician and the patient. However, and I'll touch on this in a few slides, technical issues can potentially cause some problems, and at least compared to the telephone, there's a need for a higher level of technology literacy. So this trial from a couple of years ago now evaluated the effectiveness of physiotherapy delivered entirely via video call. So in this case, it was Skype, back when people used Skype, and it involved a home exercise program and 7 consultations over 3 months in 148 people with knee OA. So briefly, participants in the intervention group also completed, on top of the physio consults, an online pain coping skills training program. And then this intervention was compared to an online education only control who received access to a website with information about managing OA. So findings showed greater improvements in pain and physical function in that intervention group, both immediately post-intervention at 3 months, and these improvements were also sustained at 9 months. And there were also improvements in many secondary outcomes as well as global ratings of change. Another trial from a couple of years ago similarly examined 2 interventions that were delivered entirely via video call, so in this case Zoom, and that was in 414 people with knee OA. So briefly, that first intervention involved an exercise and physical activity program combined with a weight loss diet. So participants had 6 Zoom consults with a physiotherapist and 6 Zoom consults with a dietitian over 6 months. The second intervention group was just the exercise and physical activity program without the weight loss diet. So participants just had the 6 Zoom consults with a physiotherapist. And both of these interventions were compared to a control group that received access to a website with general information about OA and its management options. So results from this trial indicated that both of the intervention programs led to greater improvements in pain relief and physical function, as well as reduced willingness to consider knee joint replacement surgery. And that combined diet plus exercise program, compared to the exercise only, led to obviously large weight loss that was largely sustained at 12 months, as well as some small additional pain and function benefits and decreased use of pain medication. We also conducted a cost effectiveness analysis that was nested in that RCT I just presented. And it found that, as you can see, we were 88% confident that the diet plus exercise intervention is cost effective, and 53% confident that exercise is cost effective compared to the control. We were also 86% confident that adding that diet component to the exercise program was cost effective compared to that exercise program alone. More recently, just last year, a non-inferiority trial was published in The Lancet that compared video consultations with a physiotherapist to traditional in-person consultations for a home-based exercise program, as well as education about OA and its management. And all participants also received things like printed educational resources and exercise resistance bands. So participants in both groups of this trial received essentially the same intervention. It was just how it was delivered was different. So they all had 5 consultations with a physiotherapist over 3 months. And results indicated that both the video and in-person consultations led to similar improvements in symptoms, and that the video delivery was non-inferior to in-person care. So the number of adverse events between groups was similar. And in fact, as you can see, video conferencing was superior for some secondary outcomes, including things like change in physical activity, ratings of therapeutic alliance, participant satisfaction with the intervention, exercise adherence, as well as attendance at consultations. And of course, they travelled less distance for their consultations as expected. So as I mentioned a few slides previously, one sort of criticism of doing consultations via video call is the potential for technical issues that might disrupt that consult. So this descriptive study was nested within that non-inferiority RCT that I just presented on the previous slide, and it investigated the frequency and impact of technical issues during video calls. So what they did is they audited a number of consultations, and they found that technical issues occurred in 37% of initial consultations and 19% of final consultations. So this was most frequently problems with the audio or the video, and was obviously predominantly experienced during setup. But they found that this didn't significantly increase the duration of the consult. So they concluded that while technical issues with video calls do frequently occur, they were typically very minor and were able to be resolved quickly. So the next modality I wanted to focus on is websites. And so these are often self-directed tools that are free for consumers to access without needing to pay to see a clinician. So these can be really accessible for those with financial or other barriers to care. So this first study conducted a scoping review to evaluate whether pain management websites included best practice support strategies, and also to do an assessment of website quality. So they evaluated 27 relevant websites and found that the top 3 based on their evaluation was the My Joint Pain website, Live Plan B, which is run by Pain Canada, and ACI Pain Management Network. So they suggested that clinicians could refer people with persistent pain to these websites. But in general, they did find that websites were of poor quality, with only 6 of the 27 they looked at having HON code certification. So that certification shows that the health information presented on the website is reliable and credible. And it's a free certification to obtain. And in addition, only 2 of the websites had been evaluated as part of a study. So many are not necessarily evidence-based. So one such study that evaluated one of those top 3 websites was this one here, completed a little while ago now. So they evaluated outcomes after using the website My Joint Pain. So this website contains tailored evidence-based information and tools that aim to improve self-management of OA and support change in knowledge about OA. So they used a quasi-experimental design to evaluate the website over a 12-month period in 195 people with hip and or knee OA. And they found that use of the website did improve people's perceptions about self-management and also their self-efficacy to manage their pain after using it for 12 months. And other types of websites can also be effective. So these 2 programs, so essentially self-directed exercise programs. So the one on the left, the Mining Exercise, focuses on resistance exercise for OA, and the one on the right is yoga for OA. And they're self-directed in the sense that users don't have to have any contact with a clinician, and instead they're guided through the exercise program by the website, sort of at their own pace and at no cost. So both of these websites have been tested in separate randomized control trials. So briefly, the Mining Exercise program on the left was compared to education-only control in 206 people with knee OA. That was over 6 months. And then the My Joint Yoga website was also compared to education-only control in 212 people with knee OA, with outcomes measured at 3 months. So the My Knee Exercise website led to improvements in knee pain and function, as well as a number of secondary outcomes that also favoured that intervention group. The My Joint Yoga website was also found to improve function, but not pain at follow-up. But there were other benefits to secondary outcomes, including reduced knee stiffness, increased quality of life, and better arthritis self-efficacy. Short informational videos can also be beneficial for people with OA. So for example, this RCT compared two different educational videos. So briefly, both of these videos were of about the same duration and they covered the same topics on management of knee OA. And the content in both videos was based on current evidence and clinical practice guideline recommendations. But the key difference was that the experimental video avoided the use of imagery and descriptions that related to structural joint changes. And that experimental video also incorporated a consumer voice and experience. So this RCT found that compared to the control video, that experimental video led to improvements in people's self-efficacy for managing their OA, reduced their fear of movement, and that people in the experimental video group also demonstrated greater improvements in some secondary outcomes, including belief about the importance of exercise, their motivation to be physically active, their knowledge about knee OA, and they were also less concerned about their knee OA getting worse in the future. So this study shows that a simple, short informational video can have favourable effects on people's beliefs and attitudes. So I've focused a lot on sort of exercise and weight loss interventions so far, but there's also some evidence that psychological interventions that promote pain self-management can also be effectively delivered via digital modes of service delivery. So a few years ago now, a fully automated 8-module pain coping skills training program called Pain Trainer was developed, and it covers techniques like relaxation, pleasant imagery, and coping thoughts, etc. So I don't have time to go into it in great detail, but an RCT showed that this program can reduce pain and also reduce the number of maladaptive behavioural strategies in people with OA. And a follow-up qualitative study also found that users have generally positive experiences using the program as well. Again, so far what I've presented are really sort of standalone digital interventions that are used without any in-person contact. But of course, digital health can be used as part of a stepped management approach before moving on to more costly and intensive treatments that might involve clinician input. And indeed, this trial that I've shown here on the slide evaluated how a blended model of digital health and in-person care could be used in a stepped exercise program. So their RCT compared this stepped approach to exercise management with an education control. So briefly, all participants in the stepped care arm started on this automated web-based exercise program without any clinician input. And then after 3 and 6 months, if they didn't improve by a clinically relevant amount, they then stepped up to the next levels of exercise treatment, which involved contact with a health coach and then eventually with a physiotherapist. So they found modest improvements in knee OA symptoms at 9 months compared with control, and concluded that this stepped care model incorporating this digital approach might be an efficient way to deliver exercise therapy, as you're obviously not using up resources when a proportion of patients don't actually need more intensive treatment. And lastly, I just wanted to touch on mobile apps or SMS. So this can obviously be used to deliver different programs and interventions, as well as increase adherence to a treatment, help people track their symptoms, and communicate with a healthcare team. So in terms of apps, some recent evidence found that there's a real paucity of high quality OA apps. So this study, which is a couple of years old now, conducted a search and assessment of the quality of OA apps that are currently available in app stores. So they identified just over 1,000 apps, the vast majority of which were deemed to be of poor quality. So only 14 apps were of high quality that went through a more rigorous assessment. And they were mostly apps related to things like symptom tracking, exercise recommendations, education, goal setting, and apps to improve general well-being. But many of these apps did fail to provide comprehensive education and they lacked scientific testing. So the authors concluded that future research should focus on developing and evaluating apps that fit the needs of healthcare providers and patients, including things like exercise programs that are tailored to individual needs, as well as protection of health information. A few years ago now, a study evaluated the effectiveness of an SMS intervention that was designed to help improve adherence to home exercise in people with knee OA. So I'll show on the screen in a second what that SMS program does in just a moment. But briefly, 110 people were randomized to either an exercise group alone or to an exercise plus SMS group. And the trial found that at 6 months follow-up, that SMS group reported higher adherence to their exercise program and they exercised more days in the past week. Though interestingly, that didn't actually translate to improved clinical outcomes. So as I mentioned, that SMS program looks a bit like this. It's actually been converted into an app now, but just to give a very quick idea of what it sort of does, users are asked to nominate how many days of the week they're aiming to exercise, and at the end of every week are asked to self-report how many days they actually did their program. And if they don't meet their target, they're asked to nominate some reasons why, so what made it hard for them to do all of their exercise sessions. And depending on the reasons they choose, they get some personalised feedback or tips for how to overcome that particular barrier to exercise. And they can also use the app to track their exercise frequency over a number of weeks as well. Finally, I didn't actually mention AI at the start, but wanted to really quickly touch on it now. And it's definitely an emerging and a quickly developing area. And there's already a bit of emerging evidence, and I just provided a very quick example here, that AI has some potential to provide people with advice and guidance about their OA. So briefly, in this study, they aimed to evaluate how well the information provided by two AI programs. So in this case, it was ChatGPT and Bard, which I think is Gemini now. How well that information aligned with clinical practice guideline recommendations for management of hip and knee OA. So both AI systems were asked about 10 different types of OA treatment, prompted by a question like, is exercise recommended to treat knee OA? And overall, the authors found that AI responses were concordant with the guidelines for about 60 to 80% of treatments that were queried. But they did note that the AI failed to discourage some treatments that guidelines actually recommended against. So they concluded that AI doesn't yet consistently provide treatment recommendations that align with guidelines. But of course, like I said, I'm sure we'll see some more work in this area and how AI can be used to provide education to people with OA, and even potentially do things like prescribe them an individualised exercise program. So hopefully my presentation's given an idea of the research that's out there providing evidence to support the effectiveness of digital health in the management of OA. So clinicians should be confident that there's, plenty of growing evidence that a lot of these digital tools are effective for management of OA. But of course, digital modes of service delivery aren't for everyone. And it's important for clinicians and patients to work together to decide which approach is best for each person's specific circumstances and preferences. And although there is all this evidence that digital health interventions are effective, there are still some barriers to broader uptake. So many people in the community, particularly those who've never tried telehealth before, might have negative perceptions about it and believe it's less effective than in-person care. Similarly, among clinicians, they're often not as confident delivering care via things like telehealth, and can also be skeptical about its effectiveness, which means they might be more reluctant to try it out. And of course, there are some system level challenges to implementing digital care as well, such as restricted funding. So, hopefully people can pause on this slide if they want to zoom in on any of this, but our research centre, Chesm, have developed a bunch of free digital health resources and tools for people with OA and for clinicians. So some of these might be worth checking out if anyone's interested. And thanks so much again for the invitation to give this presentation, and happy for anyone to contact me with questions or comments if they want. So my email address and Twitter handle are here. Thank you.
Thank you so much for that presentation, Belinda. It's really great to hear about all of the amazing work you and your colleagues, as well as others around the world, are doing in digital lifestyle care for OA management, because it does seem to be here to stay and is a great option for many people with arthritis. So, really great to have you explain the different types of modalities and how it's implemented both in clinical care as well as self directed. And along those lines, I have a couple of questions for you that I hope will resonate with our audience as well.
Mhm.
So first of all, I was curious. I know you have those great resources that you just shared on the previous slide, and we will send a link out to those in the follow-up email to everyone who registered for today's webinar. But I'm curious how else you promote the digital health resources that are the ones that are geared more for patients to do on their own outside of clinical care. How do you kind of promote those and get the word out to patients?
Yeah, that's a great question. And it can be tricky, definitely to make sure we're reaching patients and clinicians. I mean, we have been promoting it pretty widely on the internet, so using our social media channels and our Chesm websites, which reaches a lot of people in Australia. And then internationally, we've been working through the Aussie kind of rehab discussion group as well to try and reach an international audience. And working with a couple of international arthritis organisational bodies like Arthritis Australia to make sure that these resources are also listed on their website. But I'm sure there's a lot of capacity to reach a wider range of people. And yeah, like I said, it can be tricky to try and um, yeah, make sure we are reaching clinicians across the world, particularly. So I'm keen if anyone listening is happy to share the resources with their colleagues or patients, that would be amazing.
Well, and we are also excited to have the My Knee Exercise program, which you mentioned,
Mhm. Yeah.
as one of our arthritis appropriate evidence-based interventions. So that's another way
Mhm.
to get the word out. And some of the ones that you mentioned earlier kind of piqued my interest as
Mhm.
possibly talking with the developers about to see if they may be good fits for going through that review process. And I know you mentioned this, but kind of another question I had related to healthcare providers is kind of what you're hearing from them, or if you did any qualitative work or any surveys with the healthcare providers, the physios who delivered the digital care. What was their feedback? How did they feel about it?
So they were pretty interesting, similar to what I think I'd mentioned to some how patients often feel about some of the digital modes of care. The clinicians were quite often very skeptical about the effectiveness of delivering care via phone or via video call, particularly physiotherapists, because they often feel like they need to be hands-on with a patient and they feel a bit uncomfortable that that's not possible. Um, but overall, for all the qualitative studies, I'm trying to think of how many we've done with physios. There's been at least 4 or 5 different trials where we've interviewed physios before and after their experience. Um, and overall, they've all found that once they try digital care, they actually really like it and they can see it's got some really unique advantages over in-person care. So just an example, I remember physios who delivered care via telephone, so had no in-person or visual contact with their patients, they actually found that it helped really focus their conversation on self-management and there was less sort of expectation, obviously, from the patient to get hands-on care, which led to a much better consultation, they felt. But yeah, like I mentioned, there's sort of this barrier where they're quite skeptical at the start, and probably lacking confidence in their own skills to be able to provide care via digital health. So definitely some challenges, because I think that's still a sort of prevailing belief out there among many clinicians that digital health is not as effective as in-person care. So that's, yeah, a challenge to overcome.
Well, that's really interesting that you mention that bit about patients having more responsibility to
Mm,
be involved in their care and to do the exercises rather than just rely on the physio to take them through the
mm,
motions.
mhm.
That's I hadn't really thought of that before.
Yeah, yeah, it's really interesting. And they also felt, because they're often consulting from their own home, that it kind of brings the exercise or self-management program into their own space. So, they're not practicing it in a clinic with the physio, they're kind of doing it in the environment where they'll actually be doing it. So that was perceived to be a massive advantage as well.
Mm. Well, that's great. Well, we are so appreciative of your time and expertise sharing about these great tools, and we thank you very much for your presentation today.
Thanks so much. It was my pleasure.